Hi everyone, Julia here from the Fullwell team, and I'm thrilled today to have snatched just a few moments of time from Dr. Brian Levine, one of the founding partners and practice director at CCRM in New York City. Dr. Levine is a double board certified doctor in both reproductive endocrinology and infertility and obstetrics and gynecology. He's got extensive experience treating kind of everything on the whole fertility spectrum. So PCOS to IUI and IVF, LGBTQ reproduction, even gestational surrogacy, which he's really passionate about, and we'll talk about it a little bit more later on. He also happens to be the CEO of Nodal, which is a surrogacy matching platform that is honestly making some big waves in the industry and bringing a lot of families closer together. Dr. Levine is known and heralded for kind of normalizing a really open and candid dialogue about fertility and infertility with all of his patients. He's really good at meeting them on their level. So I'm thrilled to talk to him today and introduce you to Dr. Brian Levine.
Well, thanks for having me today. I really enjoy talking about infertility because I think it's such a big black box for so many people. It feels like in a city like New York, there's a fertility doctor almost next to every single coffee outpost or Starbucks. But in reality, we're a really small field, right? Like only 45 of us come out of training in a year in the entire country. There's only 450 fertility clinics nationwide. And so there's actually not that many fertility doctors.
What stage of preconception are most of your new patients coming into you at? Like what age, how many months of trying have they undergone? Are there any specific like diagnoses that you see a lot in your like first time patients?
Many people start their fertility journeys in one of three different weird places. One is they started on the internet and they end up with a ton of misinformation. So that's not where you're supposed to start your journey, but it feels like the right way to do it because the internet is something private and accessible and always on. People end up going to their OBGYNs, and right, so many women may not have an internist, but at least they have a doctor that they're supposed to see once a year. And it's typically like that door on the hand on the doorknob, like right as they're leaving the office, like, oh, by the way, I forgot to tell you, my husband and I have been trying for a year and things haven't been working out. What do I do again? So OBGYNs. And then the third is what I'd call the social crawl, which is kind of whispers and words from friends and family members like, oh, Susie had a hard time. So don't think that you're okay if you're not getting pregnant quickly. Like seek help before before you go down a path you don't want to go down. Or time's running out, or oh geez, Sally, like your 35th birthday's around the corner. What are you thinking that you're not seeing a doctor? So people have like multiple different ways of how they end up at the fertility doctor's office. But when they come here, it's pretty much three groups of people. We see people who either have trouble getting pregnant, people have trouble staying pregnant, or people who want to protect and preserve their fertility. For those who are trying to get pregnant, I would say you can bifurcate that group into two groups. One are the people who are like contemplative, and they're like, so I'm not trying. Like I haven't told my partner that I stopped taking the pill because he doesn't need to know that yet because it's going to freak him out. But if I pop up pregnant, he'd be cool with it. Or you get the people of, so I'm peeing on a stick every day, but then I wrap them up and, I put them in toilet paper so that my partner doesn't know because I don't want him knowing that I'm actually trying to get pregnant, but I am trying to get pregnant. Shh, don't tell him if you meet him. But can we just talk about that for a little bit? Or then we get the people who are like, look, my husband is amazing. We're in this right now. He's like not going to the gym. He stopped his soul cycle. He swears to me he's wearing boxers. I keep seeing his laptop, on his lap when he's watching TV. And I keep telling him that the reason we're not getting pregnant is because he's frying his sperm with his laptop. There's got to be a way to get him to stop doing that. But outside of that, I think we're good. But what the heck's going on? Right. So like we see that all the time, which is like kind of like this weird contextual, like pre-contemplative, contemplative sort of trying group. Then you do see the people who are really trying and feel like they're banging their head against a wall. And they're like, look, I'm 37 years old. I had sex in May and I'm still not pregnant. And you're like, it's December, it's January. What do you mean you had sex in May? Like, I should have been pregnant, right? Like, I had sex, like, I should have been pregnant. That's what they taught me in health class. And you're like, doesn't really work like that, but I do appreciate your insight. But no, you've not been trying for 6 months because you waited to come here 6 months after your one sexual experience. Um, and what happens in no matter how people come to that point of that they're trying to get pregnant, we standardize the approach, right? So what we do is we standardize the conversation. We take a good medical history. We try to get the male history, the female history. We do blood work and we do an ultrasound. So what we try to do very quickly is no matter what someone's path is to here is to kind of standardize the evaluation of them to make sure that we have a comprehensive understanding of their reproductive potential and maybe understand why things are working or not working. Because the worst diagnosis to be given is unexplained, only second to bad luck. Oh, you just weren't lucky, try again, right? Like that feels weird. Like that, no oncologist would say, well, you got cancer and that's unlucky, but try better next time and just don't smoke and you'll be better. You'll have better luck, right? Like luck doesn't feel like it should be in healthcare with where we are today in 2023, but it's a word that people use a lot. The second group of people we see are one of the toughest, which is the people who can't stay pregnant. So they come to the office and they have a miscarriage. And sometimes they're looking for reasons, and it can either be, I think I had a miscarriage, or I know I had a miscarriage, or I felt it, I got pregnant, then I wasn't, or I know it's like peeing on a stick seems pretty easy, but like, am I screwing this up? Because one day it said I was pregnant and one day it said I wasn't, and I just don't know. And for those groups of people, you kind of have to do a deeper dive. The questions are still the same, the physical exam's still the same, the blood work is still the same, but sperm and egg are meeting. In fact, that she has at least one egg or had one egg. She has at least one fallopian tube that's open, and that he had one sperm at some point. That's all you really know when someone's had a bunch of miscarriages. So what you do is you take, again, a very objective view where you try to standardize all that data so at least you can analyze it. The last group are the people who are 32 and freaking out because their employer tells them that they have an egg freezing benefit that's sitting in front of them and that they're silly not to take it and they just need to take advantage of it. And so someone goes out to dinner in Soho and they're talking with their girlfriends around dinner and 1-2 glasses of wine later, everyone's raise your hands if you froze your eggs, and all of a sudden everyone at the table but that one person raises their hands, and that woman then says, oh my gosh, I'm going to be a cat lady. I just know it. I'm going to have a bunch of cats and I'm not going to have kids and I'm doomed. And so people come in here panic stricken. And they're what do I do to protect and preserve my fertility? Because I got to freeze my eggs because everyone else is freezing their eggs at every dinner I go to. And then they get into this mode where they start looking on Instagram about egg freezing, and then ads start hitting them. And then they start TikToking and seeing more ads hitting them. And then the content feels it's so easy, just freeze your eggs. And they're do I need new sneakers? Or do I need to freeze my eggs? Because they both seem the same price because I can finance this thing out. And so what we do, again, is we have patients come here who are hey, I need to freeze my eggs. What do I do? And again, we use the same approach of a standardized objective evaluation that affords us the ability to better understand who they are so that we can understand their reproductive potential, so we can make a plan for them to protect and preserve their fertility for the future so they don't feel left out the next time they go for dinner downtown.
All of those scenarios are very real. I appreciate you putting them in actual human terms. So when on that note, what are, you talked about fertility benefits, which we'll come back to in a moment, but what are some of the top barriers that you see for people who want fertility treatment but don't necessarily know how to access it or come into you and have trouble financing?
Great question. So it sucks that healthcare has a dollar amount associated with it. And it sucks that that dollar amount can be the barrier to having a kid. But the worst scenario is the empty wallet with the empty bassinet. And so many people are aware of their financial limitations. And it's not you get what you pay for, but there are certain costs associated with it because for some reason, our society as a whole doesn't understand that infertility is a chronic health condition, right? They think it's elective, Brazilian hair straightening. Um, you know, maybe there's a girl out there who's crying herself to sleep at night because her hair is curly and she really wants straight hair. But I can tell you that there's many more girls who are crying themselves to sleep at night because they don't have a kid when that's all they want. It feels like an inalienable right. And it seems something so simple that even their dumbest friend got pregnant very quickly and they don't understand why it's like not working. And so for the barrier of cost, what we try to do is to help people have complete transparency into the costs associated with infertility treatment and diagnostics. And then we work with them. So yeah, there's a bunch of different employer-based benefits, like Progeny is the famous one, and Maven is incredible, right? They're a telehealth platform that also is an employer-based benefit. There's Carrot. There's a bunch of different opportunities out there for people to work with employer-based benefits. There's like brick and mortar standard insurance companies like Aetna and Cigna and Blue Cross Blue Shield and Anthem and yada yada. Um, and then for those who still don't have any of that stuff, because maybe they work at a startup and maybe the company's lean or whatnot, they there's financing options. And so like someone like Future Family, which is incredible, where they have kind of like come out with some products where like the interest rates are like close to nothing, and or Sunfish, which is like a new startup that's super exciting in the financing world, or Gaia, which is a group out of Europe that's now coming to the US. Um, the fintech approach to fertility is, I think, going to be the story of 2023, um, where people are saying, let's solve a problem because the barrier to entry is cost, which is the same barrier to entry to home ownership, the same barrier to entry to home, vehicle ownership. Like we've solved this many times before. Let's just make it weird and say that the widget is a baby instead of just a house.
Right. Yeah. It's really heartening to see all of the kind of like new benefits available. I have a friend who works at a huge company over yonder in Chelsea area that owns all of Chelsea. But they not only do they have like really great financing and options and programs for them, they have like support groups for other women and men and couples who are going through all the same things. So let's flip really quickly and talk about men's fertility.
Sure.
Now, the the way that you kind of presented scenarios of new patients uh, kind of made it seem like you mostly see women coming in for the first time, and that partners may or may not necessarily be along for the ride. Um, do you how do you feel that like culturally men's fertility is viewed and linked within all of this?
To me, um, we have done a really bad job as a society, both as a industry in the fertility world, as a society, as a human, in helping people understand that it takes two to tango and that there is no reason to have a blame game. Instead, what we need to have are targeted solutions. And so, what has happened is that many women are the catalysts to seeking treatment because there are many more fertility doctors than there are reproductive urologists, right? So, if we're a small field, they're even smaller. The number of women where the diagnosis falls on the female side versus the number of men where the diagnosis falls on the male side is equal when you go to fertility clinics. So 40% of all the people who have trouble getting pregnant or staying pregnant is due to a female etiology or female cause. 40% of all the people who go to a fertility clinic, it's a male cause. And 20% is either unknown or combined, which means, it takes two to tango. But as opposed to, the most recent season of White Lotus, you don't have to go change your ingredients. But what we do know is that men are not very good at getting an assessment done of their reproductive potential. I don't blame guys for lacking the initiative. I blame healthcare industry for lacking the messaging that's required for people to understand that this is an important and valuable step. So that includes, but not limited to, seeing your internist, high cholesterol, high blood pressure, obesity, all associated with bad fertility. Lifestyle modification, smoking, drinking, stress, all associated with male infertility. History of first degree relative with infertility. Many people don't ask their dads, hey, how long did you try with mom? Or how long did you try with your girlfriend? I mean, who knows? But like, no one even asks about that stuff. Um, we just have this really bizarre assumption that if you can't get pregnant, it's her fault and she'll go get help. And then you just got to go to, watch some porn and give some sperm and you'll call it a day. And that's not the standard of care. The standard of care is understanding the etiology, the cause of the infertility diagnosis that's there. And right, the definition of infertility is performance based. There's very few performance based diagnoses in healthcare. One of them is death, right? So, like when you're dead, that's defined by no breathing, no cardiac activity. You're dead. That's your performance. But infertility, another performance based metric, your ability to get pregnant, stay pregnant within 6 months of trying. That's over 35. 1 year of trying, under 35. Those say nothing about laboratory tests. Those say nothing about x-rays, ultrasounds, all those other interventions. So if people can understand that when they have trouble getting pregnant, staying pregnant, and it's over a certain period of time, go seek help, well, that's the goal.
So when it is time to seek help, like what are some of the most common options?
So modification of lifestyle is the most common option, which people don't even think is a treatment, but they don't realize that they're being treated. Like stop smoking, reduce your drinking, take a prenatal vitamin, balance your diet, sleep like a human, live a normal life, stop telling your body that you're running a marathon, and start helping your body to understand that you're trying to prepare it to run a marathon. Sometimes people need to do what's called an insemination or an IUI or the turkey baster. Maybe it's a same-sex female couple, so they don't have access to sperm. Maybe it's a single mother by choice, so she needs to get sperm in the right place at the right time. Maybe it's a couple where the guy has performance issues. Who knows? Regardless, insemination is very easy. It's like we take a sperm in the lab, we process it, and then put sperm at the right place at the top of the uterus at the right time of someone's cycle. And then there's like the classic full Monty IVF process where people come in here and they take shots for 2 weeks, give or take. They have a procedure where we retrieve or aspirate eggs out. Eggs are combined with sperm in a laboratory. We grow embryos, right? In vitro fertilization means in a outside of the body environment. We fertilize. Literally, it's like a beautifully defined process. We grow embryos for 5 to 7 days. We can genetically test them. We can freeze them, put them back at the right time in the right place. So there's a whole bevy of opportunities here and interventions to do. They go from really low tech, like, hey, clean up your diet, to really high tech, like, hey, let's go screen for that cancer gene so that your children don't have to worry about what you worry about every day. But it's not one size fits all, right? Like you got to really offer bespoke treatment because everyone is different.
You mentioned same-sex couples, and in general, I want to talk about kind of like different family structures. And that brings me to talking about your company, Nodal, of which you're also the CEO, in addition to all of the other letters and acronyms that follow your title. Nodal, so can you it's always more exciting coming from the founder. Can you explain what Nodal is?
Sure. So Nodal is a transparent platform that allows intended parents and potential surrogates to meet and match. In short, the industry defined bottleneck in helping people start or grow their family through surrogacy, meaning having another woman carry a pregnancy for someone. The self defined bottleneck is a result of the demand outpacing the supply. So when everyone said to me, surrogacy is now legal in New York State in 2021, get excited, let's do this. And then I started seeing a flood of patients coming to me. I started hearing a flood of complaints. People started saying to me very early on, hey, this is cool that we can do surrogacy, but I can't afford that. Like this is too expensive. This is going to take too long. Like I had no idea that this is the state of surrogacy today. Like what is this? And so what I realized was that the bottleneck that was identified through patient complaints and frustrations was directly related to the matching of surrogates with intended parents, the people seeking a surrogate. I decided to attack it. Right? I have 2 little girls at home, and there's no better lesson to teach them than if they see a problem and they can articulate a solution, it's their responsibility to at least give it their best shot and try to fix it. right? I'm not trying to break a broken system, I'm actually trying to fix a broken system. And we're trying it with just one simple solution, which is to remove the supply and demand economics that have taken hold today. As I look at Nodal as a matching platform that allows people to interact, we have multiple steps and gates that allow us to screen surrogates in a very efficient, cost-effective way, to screen intended parents in a very cost-effective and efficient way. Our pricing is very low, where basically we are an affordable option to allow people for the most valuable step of their journey to be within the realm of hopefully something they can afford easily and efficiently. But most importantly to us is as we look at Nodal as a company that is completely focused on the ethical and transparent matching of surrogates and intended parents, we're staying core to our mission. That's what we sought out to do, was to help people match. We empower the surrogates by having the surrogate make the first move, a la Bumble, right? The surrogate gets to pick who she wants to work with. And that the reason we did that is we're trying to address the bottleneck and the dropout, right? The bottleneck being the matching, the dropout rate being 20% of surrogates that end up matching with intended parents and classic agencies don't end up going through with a successful journey due to the surrogate not participating in the journey. So for us, what we're trying to do is to address that early by letting the surrogate pick who she wants to work with. And we think that's going to allow for better buy-in, better agency. And what's interesting is that as we've continued to build and grow Nodal, what we've learned is that while many agencies, the brokers who currently were working in that classic system, were totally freaked out by us because they thought we were trying to compete with them, they've actually realized very quickly that we're collaborative. We don't want to do what they do. We don't want to do case management. We don't want to help people along the way of like getting their documents in line and all that stuff. Like, sure, we're going to offer products down the line. But today we're addressing the one problem that we identified early on, the bottleneck of the match. And so now we have agencies on our side and agencies as our partners. And clinics love us because we're vetting people. We're using high tech, high touch, right? So we're using really cool technology to allow us to screen people in minutes, not months. And we still have people on the front end who are calling surrogates and talking to them and Zooming with them and learning their family history and helping them to build a profile. And so if it seems too good to be true, it's not. You can go to nodal.com, Nodal.com, to learn more about it. In case you're wondering why we call it Nodal, there's 3 different reasons. The first is we're connecting different nodes of information. And so by connecting nodes of information from different disparate sources, what we imagine is that we are a platform of connectivity. So the name is actually appropriate. The second is, if you haven't realized already through this interview, I am a geek. I'm a big, big geek. And so geeky that I will tell you that Nodal is the one gene that's required for all high order mammals to reproduce. Without the Nodal gene, no embryo happens. So we named it Nodal as well. And then the last one is the touchy-feely one, which is nodes are the parts of a tree where the branches come out. And so you can't have a family tree unless you have nodes. And so if you want to have that touchy-feely moment, you know, that very Brooklyn moment where it feels so organic and everything, well, that moment then could be Nodal is directly related to family trees starting. So 3 different ways we got the name, but it's one big goal, which is to help people start and grow their family through surrogacy.
I am one for a Brooklyn moment. I think the thing that I became most excited by with Nodal is that we're all kind of in our own bubble like culturally, especially when it comes to fertility, because it's already such a fraught issue for some. I just didn't understand kind of the range of different types of family structures that can be helped by surrogacy. A lot of like the story of the single mother, you know, coming in to have a kid on her own, or without a partner on her own is a little bit more, accepted and noticed. But there are also single men out there who want to be fathers, and like we were saying, same-sex couples. So I think it's really cool. Just last question, what are you looking for in your surrogates? I know that it is a vetting process, but it's also kind of like a really cool way to give back if you're among the community who is able to. So what do you look for when you're screening surrogates?
So, as someone who is a proud Eagle Scout and went through the whole Boy Scout process, it almost feels like we're going through like the 12 tenets of scouting. We want someone who's courteous and kind and obedient and cheerful, and you can go through the whole list. But in reality, we want someone who's safe, and that's what matters the most. The
Mhm.
safety of the process is paramount to who we are and what we're doing. What we want to see through our company, Nodal, is that we are screening surrogates better than anyone can, so we can help reduce the risk to this woman who's willing to make this unbelievable altruistic offer to help another individual or family. We want to limit the risk to the unborn. We want to try to help people find a surrogate that's going to have a full term delivery, not a preterm delivery, not a complicated delivery. We want to try to find someone who is in a healthy family, a nurturing environment where that surrogate can do her best to give the best to that family. It is so important to us that we make sure that the health of this entire match works, that we actually are seen sometimes as a little too strict, but that's okay. I would rather be strict than be sorry. And I, as a physician, recognize very clearly that a surrogate is making an unbelievable opportunity to an intended parent. But that opportunity is one at risk to her own family, because you can't be a surrogate unless you have a family already. And so to respect that relationship and respect that heavy lift is so important to us, that we want to screen people to the best of our abilities. And so what we're looking for is for someone who's medically cleared, psychologically cleared, socially cleared, of the right frame of mind, in the right environment, doing it for the right reasons. And if that sounds way too restrictive, I'll tell you that in an industry of only 5,000 surrogacy journeys a year in America, yes, that's correct, 5,000 successful journeys happen in America in a year. We have had over 6,000 women apply to work with Nodal in the last 3 months. So our messaging is doing something right, and we're able to garner interest. And so we think we're going to continue to do what we set out to do from the beginning, which is to help people start and grow their families in an ethical way with surrogacy, which should be much more affordable and much more accessible.
That's amazing. Thank you so much for your time today. I know you're busy and scheduled out in every minute of your day, so I really, really appreciate you joining us.
Thank you. I appreciate it.
Be sure to check out all of the work that Dr. Levine and his amazing team are doing at nodal.com. We'll see you next time.